Okay, this video is for the second part of the musculoskeletal system. I really am going to go through it pretty fast. You are encouraged to ask questions if you have, which you never do, and is weird, but good luck. Uh, a lot of the ideas here just have to do with, inflammation or infection and are repeating itself so many times. So what I suggest that you focus is not on if there's going to be inflammation. There is going to be inflammation. Um, but the idea of what causes the diseases in particular and what are the unique signs that differentiate them from one another. So let's go to slide 10. We're talking about OA, osteoarthritis. This is an age-related disease that affects the joints. We see that it's characterized by both the loss of the articular cartilage and the loss of the formation of new bone formation. So double whammer, you're losing bone and you're not forming new bone. You can see that it causes a change to the subchondral anatomy of the bone. You change anatomy, you change function. You know that. You can see that the joint and the joint capsule is becoming thicker. And I just want to remind you about the idea that the cell or tissue or a joint does not have unlimited space. So when you start growing into the joint, you immediately are creating two things. The loss of range of motion, and at some point it's going to apply pressure, mechanical pressure, on the pain sensing nerves, and you're gonna feel pain. Any sudden movements, any increased force, the more force applied to the nerves, the more pain you're going to experience. Then you can see that obviously the load-bearing areas of the body are at higher risk to develop OA than others, naturally, because of the mechanical pressure. And we can see that although we believe we understand the mechanism, it's still idiopathic. Then on slide 13, notice the second bullet that in women it's severe, more severe. That is true for anything that has to do with the skeletal system and calcium balance in general. Then on slide 14, notice that in the third bullet, the cartilage becomes thinner or absent, and that of course is going to cause a lot of pain and a change to function. Let's see. Slide 16, once again, first bullet, changes to the anatomy of the bone immediately has to register with you as changes to function. In this case, it's because of the limited space of the joint, and this is a very important mechanism or process to notice in the next few conditions. Then if you look at slide 17, I just want to refer you to the second bullet, to the hallmark, the loss of the proteoglycans from the cartilage is a hallmark of the disease, and also causes fluids to enter the area because of a change in the gradient, something that you heard of before. And the increase in fluids brings an increase in mechanical pressure, which is not going to help. You can see on slide 18 that a person can be asymptomatic up to the age of 40. That's half of your life, and you might be living half of your life thinking that everything is okay, but it's not. Then in slide 19, in the third bullet, of course, if we have hemorrhage, that hemorrhage, it means that you're losing blood. You have a leak of blood somewhere. Blood is fluid, so we're back again to that mechanical pressure that is just gonna interrupt and cause pain and is a bad idea, and of course limit the range of motion. But that also means that you have a leak of blood somewhere, and that's a bad idea. Then on slide 20, the first point, obviously all these sounds are originating from friction because you have tissue, bone tissue in this case, growing into the joint space, and that causes bones to grind, and that causes pain, and it causes range of motion limitation again, and of course it causes noise. Then you can see a very important bullet, the first bullet on slide 21, where we're talking about changes to actual gait, meaning changes to movement. Now, besides it being aggravated and uncomfortable, remember that if we were in the jungle, then it would have implications on survival, and that's very important to understand. Now we can start talking about arthritis. Arthritis, you can see that we have changes to the membrane. And I want to remind you to go back to the basic anatomy and remember that the membrane of the cell serves two major points or processes. First of all, it by definition defines the cell. Then it is the way in and out of the cell. So by definition, it is a cardinal aspect of life of the cell or the tissue. In addition, in the first point on slide 23, you see that we have systematic signs of inflammation, meaning it is not localized anymore, it's in the system, and that's a bad thing. Then on the third point on slide 23, you see that we have an invasion from the outside of some kind of infectious factor. What else? Slide 25, the second point, when we're talking about RA, notice the word distinguished, meaning this is unique and you should notice it. We're talking about a chronic, systemic, inflammatory, autoimmune disease. And my question is, what can go wrong? Then you see on the first bullet of slide 26, and also on the second bullet, the amount of tissues and organs that are affected. And really, the question is, what is left untouched, I wonder. And yet it's still idiopathic. Then you see also, it's going to affect the skin. It's affecting the lymph nodes. It's affecting spleen enlargement. It's causing spleen enlargement, and so on and so forth. So really, no stone untouched. In regards to slide 27, notice once again that we're talking about risk factors, because that's the way that we symbolize that the situation is idiopathic. Then notice the environmental risk factors are greater than the biological, including smoking. Then on the third point on slide 27, you can see that the synovial joint might rupture, meaning that now you have synovial fluid all over the place, and that's a bad idea. Talking about AS on slide 28, I think that the second point once again leads to the conclusion that the range of motion is going to go down and pain is going to be caused. That usually comes together. And then you can see, once again, it's a systemic autoimmune disorder that is differentiated from RA mainly by where it occurs and the end outcome. So, slide 29, first bullet, you have a very distinctive definition of where and what is going to happen in AS versus RA. You see that in AS we're talking about excessive formation of bone, whereas in RA it is the breakdown of it. So in AS we are growing into the space, and in RA we are increasing the space because you're losing the tissue. Both are a pathology, not going to work. Both will lead to some kind of scarring, fibrosis, fusion, weakness, inflammation, and so on and so forth. What else? Then notice on slide 31 that the most common symptoms of AS are low back pain and stiffness. Then you can see on the second bullet that the pain increases after prolonged periods of lack of movement and exercise. That's us, at least the exercise part. Then you can see that difficulty to get up in the morning or twist the spine are also common. Continuing on slide 32 with more conditions and signs and hints to the right diagnosis of AS. You have muscle spasms as the AS progresses, so it's a progressive disease condition. Then you can literally see the diminish of the lumbar lordosis and the onset of kyphosis. And those are very advanced stages of the disease. So you can literally, in a way, according to these signs, understand how advanced the condition is or how worse it's getting. Then on slide 33, we continue with advanced symptoms with the onset of chest pain, especially during inspiration, which is very specific. You can see that later on it leads to sleep deprivation. Sleep deprivation immediately influences all the physiological, mental, psychological functions of the body. So you become a completely different person for the worse. And of course, sleep deprivation is associated, greatly and tightly associated in the literature with diseases, from cardiac diseases to pulmonary to metabolic, you name it. It's going to affect everything. You can see that tenderness of the heel and lipping is added as well. And then in the fourth point on slide 33, you have a list of other unique markers that you should notice. Then we can start talking in slide 36 about gout. Notice that it is a syndrome, not a disease, meaning it's a collection of symptoms, not a specific mechanism with specific outcomes that we necessarily can put the finger in happens every time. Notice in slide 37 and the second point, the accumulation of uric acid that transforms into crystals. Crystals are obviously a bad idea. When they form in the synovial fluid, they're going to increase the mechanical pressure, decrease range of motion, and increase pain. Then you have the gouty arthritis, which is getting worse. So if you remember, I promised you that with the advancement of the presentations, things get worse. So obviously gouty arthritis, meaning you have the toffee, the crystal deposits. When you say this deposit, it means that it's not going anywhere. Um, are so great and so many that you can actually see it underneath the skin. You can see it in the ears, you can see it underneath the skin. It's visible, and that's a bad place to be at. Of course, they can become renal stones, so why not, influence the renal system as well? And I told you that's a bad system to play games with, to mess with. Then you can see that if the crystals are from calcium, you really have crystals, but it's still called pseudo gout because it's not the uric acid. You're still in a great deal of pain, and you have a problem, even though it's calcium. And then, of course, calcium within itself is not a good matter to mess with. Then you can see in the third bullet of slide 39 that women suffer later in life, but they have worse symptoms. Advantage and disadvantage. And then you see that the best marker of gout is plasma urate. Obviously, it is elevated. Second bullet on slide 40. Is that 40? It says 42, but I think it should be 40. You see the three subtypes of gout, and obviously number 3 is the worst out of all options. Of course, I believe this is not even, I shouldn't even need to say this, but untreated becomes worse. So you have that in the fourth point on slide. This is numbered as 43, but I think the numbering lost its consistencies. Then you can see that can lead to grotesque deformities of limbs, which is an advanced situation that has accumulated with time. You're losing the structure and the definition of the joints because everything within it is changing. Then we can continue to disorders of the skeletal muscles. In general, remember that the skeletal muscles are very important, usually very protective. A lot of the pathologies in muscles are usually genetic disorders that are inherited. The conservation of genes that relate to muscle or muscles is very high. So you don't see a lot of disorders regarding muscles. They're usually genetic, and it's not easy to cause a muscle to be imbalanced for long. That is really a severe situation. So when we talk about things that become chronic, understand how hard it is to cause that effect. So when we talk about myopathies, I just want you to remember that this is a very general term used for a wide range of diseases and conditions and syndromes that may affect the muscle. So almost everything that affects the muscle can be regarded as a myopathy. I'm going to slide 48, secondary muscular dysfunctions. You can see the word secondary, meaning that it's a response to something. In this case, it's the dysfunction originates from outside of the muscle, so it's an external process. Continuing to slide 49, you can see that we can have an imbalance between ATP production or content and the ion pumps or the calcium pumps that are needed to for function of the muscle. And the pumps If you affect the ion pumps, you immediately are asking for trouble. Fatigue, lack of work capacity is the best you can ask for at that point. Continuing to slide 51, notice that the word stress does not mean psychological in this case, but mechanical. Although we do know through the HPA axis, the connection between mind and body, that psychological stress can be converted or may induce physiological stress, and we'll see it into compartment syndrome. But the word stress here relates to the mechanical aspect, and it leads to tension. Both are a part of mechanics and physics. Then you can see on the fourth point of slide 51, you have overfiring of the nervous system, of the neurons. And what I wrote to myself is that overfiring equals overforce production, which equals over pressure production, meaning that the production of force by a muscle, by definition, is applying force to an area. If you are doing that in increased rates or extent, you are by definition increasing pressure. That's the basic formula that we talked about for pressure. Then in slide 52, notice that when we're talking about disuse atrophy or immobility, we're dealing with the principle of stimulus response, whereas the lack of stimulus will cause the lack of response and will lead, in this case, to a negative adaptation. Then notice a very interesting fact on slide 53, the loss of 3% of strength per day, not per week, not per hour, per day, meaning that within a week, you would lose 21% of your strength. That's a lot. That's a lot. That's a very tricky slope. And then you can see on the third bullet that within a year of misuse, which is a long time to not use a limb or a part of your body, you lose the regeneration abilities of the body in that case. Talking about FM, we're talking about a chronic syndrome characterized by diffuse pain, fatigue, increased sensitivity to touch. And notice the important part, the absence of systemic or localized inflammation. That is definitely a differentiating definition, using the lack of symptoms to differentiate. Remember that. With FM, you have the lack of systemic or localized inflammation. No inflammation, which is unique because we usually see inflammation. So that is very unique. 80 to 90% of FM patients are women. So in theory, 2 to 1 out of 10 would be men. Then you see on slide 56, I think it is, 55, sorry, that it can be in part related to CNS dysfunction, leading to an increase of the sensitivity of the central nervous system to touch, to pain transmission, to mechanical pressure, in other words. Muscle membrane abnormalities. Once again, you're messing with the membrane. You are messing with one of the vital organelles of the cell, and you're looking for trouble. Let's see. So we're dividing them into two, which are really easy to understand. Too much membrane activity or not enough membrane activity. Too much membrane activity could lead to either accumulation of substances or the disposal of too much substances. And not enough membrane activity may lead once again to accumulation of something or not enough disposal. So you're playing between these two optional outcomes through four different options. Then you see that it's secondary, so it's the response to something, it's the result of something else influencing the membrane. We can talk about potassium and calcium and sodium, which are the two major ions of the ionic pumps that reside within the membrane, and they are cardinal to the function of the cell. Without them, you don't really have a functional cell. You have something sporadic and random, and this can lead to periodical paralysis, meaning that while the pumps are impaired, you are paralyzed. When they are not, you're not paralyzed, and obviously anything temporary can become permanent. Then when we're talking about TPP, we're talking about the increase of flow of potassium into the cell. This is going to flip the cell on an electrical level, which immediately has to register with you by now, meaning two things. One, it's gonna affect the nervous system, right? You know this. This is not new. And two, it's gonna register on ECG at some point, which you know how to read. All right, metabolic muscle diseases. I think that most of the materials are pretty simple. We're talking about usually the inability to break down a certain substance. That means immediately two things. One, if you can't catabolize something to create energy, you're going to have to catabolize something else. So if you can't catabolize carbs, you're going to divert to fatty acids. Proteins, amino acids are always last, so it's not a good idea, right, to break down your muscles. So the main game is between carbs and fatty acids. If you can't break down fatty acids, you're going to break down carbs more. So that's basically what we're talking about. Now, you are catabolizing something else more, but at the same time, you're not able to catabolize a certain substance, so it's going to accumulate within the cell. And this can lead to multiple problems. The two main ones, but not only, are one, you don't have limitless space in the cell. So you're starting to accumulate substances in the cell, and at some point the cell becomes dysfunctional. Okay, it's like hoarders and their houses. The house becomes dysfunctional. Second thing is, when you have overaccumulation of substances, these substances can be reactive. For example, glucose loves to pair up with proteins. At certain levels, it's great for function, like the immune system. At certain levels, it becomes horrible. Like, for instance, the coating of hemoglobin by glucose, which is a distinctive sign of diabetes, which, as you know, I'm the number one person that will tell you that diabetes is simply horrible. It's horrible. It's one of the most horrible diseases possible. So when we're talking about GSDs, accumulation, or what we call storage diseases, those are the main points. Now, when you read through the next slides, just notice that. Okay, the space issue comes back again, and the chemical influences of the substances appear again. Then I want you just to notice, and hopefully you'll remember this, look at slide 73. There are a lot of people that are, especially us, by the way, the exercise science professionals, we identify people as having, or we tag them as having exercise intolerance, and we don't think that the majority of exercise intolerance actually comes from storage diseases. So I hope that as clinicians, you remember this. And if you ever tag someone as exercise intolerant, you tell them, you know what, Moran, I suggest that you be tested for any storage metabolic disorders, because they usually come hand in hand. And you'll see that a big percentage of them will come back and say, how did you know that? Thanks for finding that out. All right, next topic, slide 75, sorry, is inflammatory muscle disease, myositis. Seems like charted waters for us. We know a lot about inflammation. We're talking about different levels and reasons for inflammation of the muscle fiber. And then you can see the list on the last bullet on slide 77, PM versus DM versus IBM or IIMs. Basically, very subtle differences in the definitions, right? Polymyositis means you have inflammation in multiple areas. Dermatomyositis means that it's coming from the skin and has a connection between the muscle and the skin. Inclusion body myositis, right, is getting worse. You're talking about a whole body aspect. Then you have idiopathic inflammatory myopathies, meaning that we do not know the mechanism that is leading, that is causing the condition, the results. These are this is a group of autoimmune diseases, meaning that the immune system is targeting for different reasons and in different ways the skeletal muscles. Then you can see on slide 80 in the second bullet that it is multi-systematic, so it affects more than just the skeletal muscle. And I think that should be obvious at this point, because there's no way a muscle is functioning without the backup of multiple systems. Then notice on slide 81, the hallmark for DM includes a purple rash. I've heard of purple rain. I've heard of deep purple. Now we hear about a purple rash, which is unique, of the eyelids and the lesions on the skin. So that is extremely unique. You can't miss that. Once again, you can't miss that. Remember that. Then you can see on slide 82, the first point at the end, it's talking about ER stress. We're talking about the endoplasmatic reticulum, and that will affect the ability to utilize oxygen, of course, and conduct force in the muscle. And then you can see in the last point on slide 82 that IBM, contrary to PM and DM, does not improve with treatment or drugs. Very important. Toxic myopathies, I think that the name says it all. You already learned about cell injury and toxins. We're talking about toxins that are going to affect the cell. Obviously, just a very quick reminder, it can be toxins from the environment, or it can be substances within the body that accumulate and then become toxic because of the increased concentration. Whereas in normal concentrations, they are not toxic to the cell. So remember that. There's two options. Then how nice, slide 87, last point. The most severe complication is rhabdomyolysis. You know what to do if someone has rhabdomyolysis. Now, believe it or not, I forgot about this, but last year, last semester, sorry, this unit was the last of the course, so hence the jokes at the end. I just forgot that they're in the presentation, so you're not there yet. All right, that's all for the second part. Have a good one.